Welcome back to Med Matters, the podcast where we explore the future of medical education through a lens of innovation, equity, and accountability. Today, we're going to be tackling a subject that's really, really important to OBGYN educators around the country as we're thinking about the landscape of the changing requirements and surgical volumes in residency and fellow education. So one of the things we're going to be focusing on is what happens to surgical competency when procedural volumes decline, and specifically focusing on total abdominal hysterectomy and total vaginal hysterectomy numbers, as those numbers have been declining nationally over the past decade. With me is Dr. Abhi Sripad. Hi, Dr. Sripad.
Hello.
And we have a special guest to join us in the conversation today, Dr. Leslie Clark. She is not only an academic GYN oncologist, but also someone who has been very intentional in improving surgical training in this space, specifically at UNC. And I'll let Leslie introduce herself.
Hi there, I'm Leslie Clark. I'm a GYN oncologist, as Dr. Young said, and I am really passionate about surgical education. So I'm excited to be here talking about what we're doing to improve that.
Cool. So I'm going to let Dr. Shripad start this conversation as both he and Dr. Clark are gynecologists, and then we will have a nice discussion. But I think this is really something that we as a specialty need to tackle, just because, and I can speak for myself, when I was in training, we weren't necessarily dealing with this issue of trying to find cases constantly for our trainees. But Dr. Shripad or Dr. Clark, what do you think about the current environment so far?
Yeah, I think, a great place to start is, thinking about how minimally invasive surgery has transformed patient care. And it certainly, for a number of reasons, transformed it for the better. With that evolution comes, an educational challenge. As you said, the just sheer numbers are changing and the sort of, the mix of the numbers for residents who are coming through OBGYN residencies is changing. And so I think maybe a launching point for our discussion can be how do we ensure residents graduate competent in the modalities that maybe we're moving away from, as in open and vaginal techniques, when those cases are less common. So Leslie, maybe some initial thoughts about sort of how we approach that in general.
Yeah, so I mean, I think that we've seen over the last few decades, the numbers for abdominal hysterectomy continue to fall, which is a great thing. And COVID certainly put a big, change on our volumes, and I think really brought everything to light at UNC, where we really wanted to be on top of it and be sure we were, getting our numbers and our volumes there. So I think those were sort of two things that were kind of happening at the same time, right? The rise of MIS and then the impacts of COVID. Um,
Yeah. And is there, in addition to, your role as fellowship program director now versus, we won't date ourselves and say when we all went through medical training, but, what are some of the differences now and today? Maybe, of course, we just sort of alluded to the mix of cases, but, that and just generally approaching surgical training now versus maybe 10, 15 years ago.
Yeah, I mean, I think one of the kind of big things that come to mind are autonomy. I think that for good reasons, the faculty many moons ago were maybe less present or allowed, running two rooms, sort of less autonomy earlier in training. And I think that that sort of shifted over time where, the faculties are always present, they're there. And so that does change maybe how our residents are exposed to training, hopefully for the better. But then also just the complexity of surgery. As minimally invasive surgery, surgeons are pushing the limits. There's more and more surgery that's just done minimally invasively. And so, yeah, that landscape is really changing. The case mix and the number of subspecialists and how, subspecialized and how many different surgeries can be done minimally invasively certainly peels away the number of open surgeries that we're doing.
And when we think about kind of skill development in general, somebody graduating from a general OBGYN residency, do you at this point feel that we're kind of losing the skills in open surgery, or are they just sort of becoming concentrated as a reflection of, the numbers that people may get with minimally invasive techniques versus, open hysterectomies, open myomectomies, things like that?
Yeah, I don't know if we're truly losing the skills. I would say that, I think that whether or not an OBGYN graduates competent and ready to do that has a lot to do with an individual's skills and personality and goals. I do think that these surgeries are sort of being primarily done probably by oncologists in practice. And so I think it really opens a question of how we support people following their training and kind of what is the expectation of how much or how comfortable someone should be following that training. I think that, you and I have talked about this, that surgery is, it's not just the steps of a procedure, right? There's principles, and that those things should not be lost and definitely need to be taught, whether it's open or MIS, right? That there's principles that are really what we're here to teach people.
So you bring up a good point, and we've kind of been suggesting this earlier about competency-based education.
Mhm.
So I'd be curious to know what if I'm a resident and I am expected to, have the full breadth and depth, especially by the end of training. You as an attending, how do you deem me competent? What's your definition of competent when it comes to folks that say, hey, I think you're competent to do a TAH?
Well, I mean, I think at this point we try to use our milestones, right, to determine that, and at UNC through our, clinical competency meetings. But I think that it is a subjective thing whether or not someone's competent. Certainly, um, my expectations would be in terms of steps of procedure, knowledge of procedure, tissue handling, being able to troubleshoot, that those are all the things I'm looking for to deem someone competent and kind of leads into some of where medical education, is and should be going towards sort of when is someone competent and entrustable as opposed to have they done 25 open hysterectomies.
Mhm. Yeah, I think the thing that we notice is, we really want people to get numbers, right? And so all of us as program administrators across the country are fighting with our friends at the ACGME to make sure that our numbers are met, right? But are we as educators asking the question, just because someone has XYZ amount of numbers, are they capable and competent to perform a procedure safely, effectively, and for the right patient? And so that is where things come into play, particularly in the landscape of medical education, not just in like, in my world in operative vaginal delivery, but like in this landscape where there are procedures that, there are lots of folks that are losing, not able to execute the skills that we may think that they should need, having gone through training years ago. Um, so you have done some work in the landscape of improving this. And so if you think of our resident case logs here at UNC, what patterns would you notice throughout the case logs of folks with respect to these procedures? And why do you think an intervention that you've done is necessary?
Yeah, I mean, I think, like I said, we definitely started paying attention in COVID. When everything was shut down and people weren't operating, we were like, wow, what's going on here? And we started really following the numbers. And to your point, the numbers are the floor of what we owe our trainees, right? We owe them the numbers, but what we really owe them is the competency. But so to answer your question, we noticed the TAH numbers going down in line with national trends. And so that really pushed us to say, well, how do we make sure every open hysterectomy matters? How do we make sure, the trainees get the most out of every case? And then did some work surrounding that to really be sure that the numbers weren't the only thing that we were focusing on.
Okay. And even if the procedures were performed less frequently, or like in situations like emergencies or hemorrhage or where there was complex anatomy, those have not disappeared. So what do residents uniquely learn by doing an open hysterectomy that they may not develop in doing a minimally invasive technique?
Yeah, I mean, I think the big things, right? The anatomy doesn't change, but how you expose it does, right? When you're doing something minimally invasive, where you pull or how you provide traction is different than when you're open. The concrete skills like clamp cutting, tying, those are all very reproducible and things that could be simmed, but the really emergency management of hemorrhage open, is a really big piece that you can't replicate with MIS and even with SIM is nothing like having to actually be there and think about what are the instruments and skills you need, what are you calling for, how are you communicating? Those are things that certainly can be simmed, but are really critical pieces in these really complex cases.
I guess just to jump off that, what I guess in my training, and Dr. Sripad can speak on this as well, we were told like, oh, you cannot see a TAH, you cannot do a TAH, you cannot be in one until you're at least a PGY 2 or 3.
Hmm.
Um, when I was in training, like the vast majority of our TAHs were done with either benign or oncology. Um, and so my attendings would say, hey, have you seen one of these before? I was like, no. Or have you done XYZ in this case? No. You were not allowed to do that because you hadn't done anything before. So how do you train individuals who are not being exposed to certain procedures? And conversely, as a trainee, how do you get your attendings to actually teach you? I guess that's a question to both of you.
Well, I guess I can go first. It's interesting that your experience with TAH is when I was an intern, my chief broke her hand the first week of the rotation. So I actually got to do quite a bit, but that's a little bit anomalous. I think that your point about that quick check-in, I think we're growing more and more in our sort of assessment of the learner preoperatively, what their goals are, and oftentimes sort of basic understanding is how much they've done before. And that can be limiting because, like you said, if they haven't done a lot, then we're less likely maybe to give them more autonomy. I think that one of the things that I try to stress is there are transferable skills. And in our world, everyone's trying to get vaginal hysterectomies. And, one of the key steps is the anterior entry. And almost everybody, when you ask what they're going to be working on, says that. But you really get a sense of where people are in their learning trajectory as to how well they can define what they need to do or what their next step in like feeling comfortable with the entry is. So I think that your point about the numbers heading into, a TAH or TVH are very relevant in terms of what a learner might be given in autonomy. But there's also a lot of intermediary skills and steps that they can learn from different procedures that they can apply. And I think that that is something that Dr. Clark alluded to in practice. Say you graduate with 20 TAHs, but then on your 21st in practice, you get anatomy that you're not familiar or at least had seen in an operating room. You have to figure it out, right? And so it essentially always becomes this sort of application of a prior skill. And I think that we lose that a lot. I think there's sort of a normal distribution of learners that come in with sort of an interest and an eye towards understanding what one skill in one case can mean for their next skill in a sort of different case. Um, but I think sort of at least getting learners to see that perspective and sort of be self-directed in their journey with these surgical skills and procedures is something that I try to have them look into for themselves. And I don't know if Dr. Clark, you've sort of seen things like that as well, but
Yeah, I mean, I think exactly to your point, there's a lot of skills that you can pick up whether you've done a TH or not. I remember being told the answer to that question, Omar, was a few. If someone asks how many you'd done, just say a few. But yeah, I think we really want to be more intentional than that. And so we've kind of set up some sims where if they've never done one in the operating room before they come in for their first open his, hopefully our residents are set up that they've at least done one in a low to medium fidelity simulation model where they know the steps, where they can say, this is my first one, but I've practiced, I'm simmed, I'm ready, and they can talk through at the scrub sync all the steps, right, and kind of set themselves up for success, so that they can get the most out of every case. I think we always had the honor of the onc intern coming down to one open hysterectomy during their rotation, and then you didn't do any more till third or fourth year. So it wasn't too far off of what you experienced. So
Mhm. So you bring up your implementation strategy for dealing with this problems. Can you walk through what you've done with our viewers as well as our listeners?
yeah, so when we acknowledged that we wanted people to show up prepared to the OR so that the faculty would give them sort of maximal opportunity, we started on the oncology service and we developed an open hysterectomy simulation model. And then we use that model, and the residents at the start of their rotation come through the simulation. So they show up to the operating room on day one, ready to go. They've reviewed all the instruments, they know they know the steps, they've sort of had the muscle memory of placing the clamps on tissue, clamp, cut, tie. And it was so sort of well received and successful in terms of residents' just appreciation and preparedness, and that we rolled it out to every group. And, one of the benefits of having so many wonderful kind of educators at UNC is that people just jumped right on board with their own models. The urogynecology group has a vag his sim. The obstetrics jumped in with all kinds of different, drills, whether it's forceps or O'Leary's, B. Lynch's, other hemorrhage drills. So it's really about sending the learners to the operating room ready to, having that a little bit of that muscle memory and being ready to really excel so that they get the most out of those fewer repetitions in some of these more rare surgeries.
And how did you develop the model? Like, did you, in terms of like low fidelity, high fidelity, how did you mimic tissue malleability, things like that?
Yeah, and it's not perfect. And I think that the simulation data would say that whether it's low or high fidelity, that there is considerable benefit to trainees. Probably lower fidelity benefits more junior people even more. But I can't take full credit. Dr. Newton, who I think's been a guest on the show, and I went around crafting stores, and we just played with clamps and fabric, and just you know really kind of crafted around until we got the right one. There's a lot described in the literature, and so we certainly took cues from other people who've come before us. And if you read a lot in the simulation literature, you can find different sort of good substitutes for different tissue or planes. So.
Yeah. And I think the sort of that sort of exercise and having the simulation to start the rotation gets at this idea of, trust or entrustment in our trainees as to what their skills are, even, if the numbers aren't quite to, our ACGME thresholds. In general, in terms of like weight of volume of surgeries and numbers versus entrustment of skill and autonomy, where do you kind of navigate that in terms of what is more important? Is there one more important? How do you weigh those two possibilities or characteristics between entrustment in a trainee and their general raw volume of, TAHs or TVHs?
I think we've probably all seen that there's, one trainee might feel like you could leave the room after 5, and another at 20, you still might want to be there watching, right? Everyone sort of has different skill sets and strengths. So, I think ultimately what we owe them is competency and trustability. And I think that again, the ACGME currently uses volume to describe that. But for me, I'm ready to, I think giving that feedback, that immediate surgical feedback, letting them know where on the scale they are, whether it's your my tip report or however you're giving them that feedback. And because if they're not up to a point where they need minimal help, then it doesn't matter if they've done 20, they need to do more. Or have some sort of mentoring out into early career to ensure that, that they get what they need and their patients get what they need.
So we always come back to the ACGME. The ACGME for our listeners and viewers is like the end all be all of graduate medical education in the United States. And recently, the ACGME developed a program called the Flexible Experience Pilot Program to deal with issues related to certain procedures that are decreasing in volume and reserving those procedures for those people that are going to planning on doing that subsequent to training. So, for example, if you know that you're going to be going into maternal fetal medicine, it probably would benefit you to do more operative vaginal deliveries as opposed to someone who is going into gynecologic oncology, and vice versa. So when we think about trying to triage who gets what procedures, as well as there are other programs in the country emerging that are thinking of tracking in residency, how do we, first of all, what is your thought on those initiatives? And how do we protect um, our surgical education to be at its maximum benefit when we are having initiatives such as these?
Well, I mean, I think it makes good sense if it's a skill you're never going to use, that saving those more rare surgical experiences for learners who are going to use them, that makes good sense to me personally. I do think though TAH is a life-saving skill, and I do feel like it's one that every board certified OBGYN should have, is my bias. But uh, I don't know. I think that we have to think outside the box though, because what we're doing is not, going to sustain us as these procedures continue to become more rare and as we need to train more people in our workforce as OBGYN. So
What do you think, Dr. Shribad?
Yeah, I think I would echo that. I mean, it's sort of this, there's a difference between what I think is like personally probably makes good sense of if somebody knows they want to be an MFM and, wants to dedicate more of their time early on to operative vaginal deliveries or, complex obstetric situations versus somebody who wants to do REI who, might not be doing that on a daily basis. You know, my it, that personally seems like it makes sense, but I was trained in a program that, the goal was to make, by the time people finish their 4 years of OBGYN residency, that everyone was going to be a good general OBGYN. And so I think that to the degree with which we can do that with different, mixes of numbers and cases, like I think we should do that. But I think the kind of common denominator might be harder to identify when that's not the same for everybody, if that makes sense. So I think it's great in theory. I think when we get, fewer and fewer numbers, how do we find more and more value with entrustment of skills rather than, actual numbers that are easier to identify and extrapolate out and remain consistent year over year over year is actually a bigger challenge than I think. I think it's a big challenge.
So I'm going to step back for a second. I'm going to play the role of a resident. Hearing this conversation, what advice would you give me as a future graduating chief resident who's concerned about their surgical volume numbers? Not that we don't deal with this every year across the country, but what would you tell me as a future graduating chief about my surgical volume numbers?
I mean, what I would say is that it's not about your volume, it's about your competence and your confidence. And so if you feel, and the faculty who've worked with you feel like you know how to do a surgery, that's the most important thing. And if you don't feel ready to independently do that surgery and you've identified that, then if you're a graduating chief resident, then we want to be sure you're doing a fellowship or joining a practice where you're going to complete that skill set if it's going to be a part of your practice.
Yeah, I would agree with that in the way, especially if people are going into practice, having very clear communication with the, partners they're joining. Because the last thing I think they and their practice and their future patients want is for them to be in situations where they're uncomfortable and things are unsafe. Um, I think that even prior to them leaving the nest, I would really get a sense of why they feel that way. I think this will probably be a common theme that I bring up because I'm a big believer in it, but sort of that self-diagnosis of what their concern is. And sometimes it comes down to folks who just need a little bit of a pep talk that actually they are meeting, by all external metrics, signs that they're ready for practice and independent practice. But I think that oftentimes, especially if it's say 6 months out from graduating, if somebody's really truly able to identify what they might feel uncomfortable about or not ready with, there might be some time to have them tailor their experience within the last few months. And I think there's no richer time for somebody to learn than when they feel a little bit of urgency. And in that, we've all been there that last few months, that last year of training, there's just a different sort of urgency that you have for different parts of, the skill set and the knowledge you're getting. So I think it depends a little bit on when that conversation is happening. If there is a certain amount of time where there can be almost like a little plan, or how do we approach these key things that you're not comfortable and we agree with you on, or is it just a matter of sort of getting your confidence up by reassurance? Yeah. What are your thoughts, Dr. Young? I mean, I think you probably see this a lot with, both residents and MFM fellows going into practice with, different levels of training, different levels of complexity that they'll be seeing.
Yeah, I think it has to do with exposure, one, um, as well as learner perceptions of their training, but also it has to do with sometimes our inability to objectively evaluate a learner, which goes to one of the initiatives nationally for competency-based education. And I think that is the way of the future. And I think it's actually going to be improving mechanisms of evaluation, mechanisms of feedback, and allowing, hospital folks that credential people to say, oh, you have been certified to do XYZ procedure because of these criteria that you've met. We are comfortable giving you those privileges. But I think it's the on us to determine exactly what are the components that make someone competent to perform certain procedures. So AAMC has a myriad of entrustable professional activities for medical students, and this is being mirrored in the graduate medical education space. Um, I hear rumblings that this is going to be happening in the TAH world, which is going to be fantastic. And so we as a community need to sit down and say, okay, in order to say that someone is competent in performing a TAH or a TVH, what things do you need to be able to perform or demonstrate to say that you can safely do this procedure independently and effectively? Does that make sense?
Yeah.
Um, and then I guess my last question for you, Dr. Clark, would be, and this is just my pure curiosity, what do you think is the most undertaught surgical skill today to our trainees?
Um, well, I think it's almost just that the like not confidence, but the piece of understanding that while when we're trying to assess competency on a TAH, we have 17 steps to check you off on. When you're actually competent is when you can troubleshoot and figure out and I mean, it's the surgery, the time when surgeries get scary is when there's no steps, right? It's not the right step. It's using your knowledge of the anatomy, tissue planes, the tools you have and safely performing it. And so I think that like true surgeon mindset is while we're focusing on numbers and steps and all these things, that really giving them that surgeon mindset of what are my skills, what is my anatomy, and how am I going to get out of a problem is what we really owe every surgeon we train.
How do we get them that?
I think they need earlier exposure and, doing these procedures sooner so that when they're in that more senior spot, those final months before graduation, they're given the autonomy they need to do that. And it might be that to truly get it, we need to coaching to follow them into early career, right?
Mhm.
When they have their own patients and when we help them get over that first few kind of independent practice cases.
Yeah, I agree. I think, getting our trainees into operative experiences as early as possible is going to really crystallize what things look like, what to do, what shouldn't be done, and then formulating your own scaffold and how you're going to do that when you're in independent practice. What do you think, Dr. Sripad?
Yeah, I think that, interesting while you were saying that we're all practicing in a very, I wouldn't say unique, but a limited sort of academic center where we're not typically operating with partners. I think in some ways, when sometimes people go out into private practice or, private groups, they are, sometimes scrubbing with senior partners. So there might be a little bit more of an informal transition or mentorship or coaching into the first few years of their career. So I thought I'd just kind of point that out. I think in general, like in terms of like undertaught, skills, you hear like famous musicians, athletes talk about how like the game slows down or the when they're playing this incredibly difficult piece, the time sort of slows down. And I think at every level of surgical training, it's not exactly the same, but you're able to sort of take in more variables that are happening in the operating room, whether that's anatomy, whether that's time of case, just the more and more you feel comfortable, the more you're able to kind of synthesize and incorporate into your surgery. So in addition to what Dr. Clark said and what you said about sort of numbers early on, early exposure, I think the sort of preparation between surgeries and after surgeries is sort of thinking about and being very intentional about what you saw, what you thought about while you were doing something, and then incorporating that into a subsequent surgery. And I think, by nature, our residents are super busy. They go on to the next thing. There isn't a lot of reflection time. And I think that's actually a skill that I think is undertaught is how to reflect and how to grow between cases, because that's sometimes where you actually develop a lot more preparation and skill than like, okay, I need to hold my scissors this way or clamp this way.
Mhm.
That like that preparation time and that reflection time is actually, I think, lost because we don't do a good job of teaching people how to digest what they've done and seen.
So you're saying that surgery just doesn't happen in the operating room.
Yeah, it just, yeah, it turns out.
So our viewers and our listeners are really accustomed to this, but we always end every episode with a med ed moment. That is the one thing that we want folks to take away from a particular episode. So, Dr. Clark, what is your med ed moment?
Well, I think that it's all about showing up to the operating room prepared, whether that's through simulation, reading, video review, preparation, so that you maximize that OR experience. And then to Dr. Shripad's point, sort of post gaming as well and figuring out how you can do better, video review, coaching, kind of taking it all in. So I would say that that's the secret to these rare surgeries is maximizing all of those opportunities.
Dr. Sripa?
Yeah, I think I'll pull, what we talked about today and also our last episode, which is a great one. Our listeners should go back about surgical simulation and teaching and med ed. But you just never know when something is going to click. So, for learners who are maybe frustrated that they can't quite get a skill or they're not seeing something, just continue to be observant, optimistic. Really keep at it because eventually things are going to click and it just sort of happens, but you have to sort of trust the process. So I think from sort of a med ed structural standpoint, there's a lot we can do with, early exposure, early skill development, but, it's kind of a combination of, a top down and a bottom up with learners sort of continuing to grow outside of the operating room so they can do all the things Dr. Clark just said to come prepared to, you know, um, to really understand what's gonna, do well for them in the operating room.
Yeah. So, yeah, I agree with both of you. I think surgical competence doesn't happen by accident. It requires intentional design. It requires us as faculty to actually be motivated to teach, to recognize where a learner may need extra skill building and have those tools imparted to the learner and actually be engaged in wanting to do that. We got that as trainees, hopefully. We should be giving that to the next generation because that will ensure that our patients get the best care as possible. But also, surgical competence requires leadership to be willing to protect educational priorities. And so, um, giving learners that time to actually do those procedures, um, carving out time to really have that reflection, as you guys had talked about, to really understand the why of why we do things, is going to be super important. We all know that numbers matter, but it's the crisis management, it's the autonomy, it's the judgment. I agree that a TAH is an emergency procedure, and a board certified OBGYN should be capable of doing a TAH. And so I think this is something that we will not just discuss today, but it will be something that we will probably discuss in many future episodes. But I wanted to thank Dr. Clark for joining us today on Med Matters for this important topic, and for all of you for listening, and for our viewers for watching. So we will wish you a wonderful day, and stay tuned to our next episode of Med Matters. Have a good day.